everyone. My name is Dr. Raquel Vertrees. I'm a pharmacist here at Kingman Regional Medical Center. I'm currently completing a PGY1 pharmacy residency, which is just getting more knowledge on the hospital side of pharmacy. So today I'm going to be presenting on pharmacogenomics, the future of personalized medicine. At the end of this presentation, we should be able to understand what pharmacogenomics is and how it applies to the human body, recognize a few examples of pharmacogenomics, apply pharmacogenomics to a few disease states, and understand the benefits and drawbacks pharmacogenomics can have. So to start off, pharmacogenomics is a big word, so to break it down, we have pharm, or you can think of that like pharmacy or medications, and then genomics is our genes. So putting that together, we have the study of how our genes affect an individual's response to medications. So today we're going to be talking a lot about pharmacology as well as our genes. Pharmacogenomics is also known as personalized medicine, precision medicine, or pharmacogenetics, and these all mean about the same thing and are interchangeable. So I'm going to present a patient, and we're going to follow him throughout the presentation to see how pharmacogenomics has improved his healthcare. So we have Carl, a 67-year-old male with depression who comes in to see his primary care provider's office, complaining of feeling tired, not wanting to eat regularly, and no longer enjoying visiting his family. These are all symptoms of depression. He has previously tried Celexa and Zoloft, however, he's still having the same symptoms. And these are both other antidepressants. So keep Carl in mind. We're going to come back to him throughout the presentation and see how pharmacogenomics can help him. So how do we know if a patient will have a beneficial effect from a medication or end up having a side effect? Well, the answer to this is that we don't really know if the patient's going to have the beneficial effect or going to have the side effect. So your healthcare professionals practice what we call evidence-based medicine, which is that we follow big clinical trials that look at drugs, and in these trials, most of the patients benefited from this medication. So that doesn't mean all the patients benefited, just that most of them did. So there's going to be some outliers in these trials. So because of this, we have the Centers of Disease Control and Prevention, the CDC. There's reported that there's an average of 1 million ER visits per year due to drug side effects, which led to 280,000 hospitalizations. And this all costs about $3.5 billion spent on treating drug side effects. So pharmacogenomics can tell us if a patient will have a side effect or if the medication will not be working for them. So we could potentially have that benefit of reducing side effects and hospitalizations in patients. And in turn, this will end up reducing our healthcare costs as well. Currently, we dose medications based on these 5 things. We have a patient's age. If a patient is older, we may assume their metabolism is slower. So we would need to dose their medications, have lower dosages for these patients. For a patient's weight, if a patient is of higher weight, they may need to have a higher dose medication. And then for kidney and liver function, if patients have reduced function in these, they may need a lower dose for that medication, as well as other medications. You may have heard of drug interactions, and this is why it's always important to tell your doctor and your pharmacist all the medications you take, because these medications have the potential to interact with each other in a lot of different ways. So for instance, we can have one medication that can increase the metabolism of another medication, or it can decrease the metabolism of that other medication. So these aren't all the things we need to dose a patient's medication off of. These are just what we use right now. There are a lot more things, and with pharmacogenomics, we can look at more things to dose that medication off of. So this is more specific dosing to individualize that medication to the patient. So with pharmacogenomics, we can take into consideration drug metabolism, receptors, transporters, targets, response, as well as high-risk genotypes. And then since we're taking in more things into consideration when dosing our patient's medication, this can in turn lead to more personalized medicine. However, it is important to note that this isn't all the factors that we take into consideration when dosing medications, so it's not going to be a perfect science just yet, at least. So now I'm going to go into the basics of genetics, just to give us some background on this topic. So our genome is our whole set of DNA, or our genetic information. So in each of our cells, we have our 46 chromosomes, which are made up of DNA, and then parts of that DNA are called genes. Now, DNA is our instruction booklet for our entire body, and it tells us, tells the body what to do and regulates everything in our body. Now, in humans, our DNA between all of us is 99.6% similar. However, that 0.4% leads to about 25 million different areas for variation because we have about 3 billion parts that make up our DNA. So that's a lot of room for variation, and that's where this pharmacogenomics comes into place. So with those genes, we can see in this photo that they code for what we call proteins, and proteins build, regulate, maintain the functions in our bodies. They're the workhorse of the body. They have many different roles. The one we're going to talk about today, which is important for pharmacogenomics, is their role as enzymes, which has to do with our metabolism. So what happens when we ingest a medication normally is our body's initial response is to eliminate that medication because it doesn't belong there. So what we have are enzymes, and these break down medications into parts that can be eliminated from the body more easily. And they are metabolized generally through our liver and kidneys. So you can think of enzymes like Pac-Mans breaking up that medication into substances that are inactivated, and then from there they can be eliminated from our bodies. Now, just to recognize the name of some of our enzymes, we have cytochrome P450. This is a large family of enzymes found in the liver that's responsible for the majority of our drug metabolism. And then from that family, we name each enzyme CYP and then a combination of letters and numbers. So for example, we have CYP2C9 for this, and that CYP stands for cytochrome P450. So this is just so you can recognize the name of enzymes. It's not important which enzyme it is. So with pharmacogenomics, we can look at how our metabolism is working. So those enzymes, we can see in the middle of this picture, we have normal metabolizers, which means that enzyme is working how we are expecting it to, and how the majority of the population's enzyme is working. However, we can have a slow metabolizer on the left side of this picture where that enzyme is not working as well. You can think of it as smaller Pac-Man than the normal metabolizer. And because of this, it's not able to break down that medication as fast as a normal metabolizer. And when you're not breaking down medications as fast, that can lead to accumulation of medication, or that medication can start to build up in your body. And when you have too much concentration of medications, that's where we get those side effects. On the other hand of this, we can have rapid metabolizers where that enzyme you can think of as a lot larger, or it's working a lot faster. So because it's working a lot faster, it's breaking down that medication really fast, and so we're not building up that concentration in the body that we need to have its effect. So in these patients, they're not going to have the beneficial effect of the medication because it's getting metabolized too rapidly. Another way we can have genetic variations between us is we have drug transporters. So these are mechanisms for the medication to get into your bloodstream. So it has to go from your stomach into your blood vessel, and then it's transported there through drug transporters. So in this photo, I have represented the drug transporters as the blue arrows. And you can see we have normal function, and recognize that there's 2 blue arrows or 2 drug transporters, and they're transporting most of that medication into your bloodstream, but not all of it. So we can have variation by having decreased or poor function of those drug transporters. So notice in this photo, there's only one blue arrow, so there's only one drug transporter compared to 2, which was the normal function. So in this instance, we have less medication getting into our bloodstream, and so it's not going to build up that concentration in our bodies to actually start to work. On the other hand of this, we can have increased function of those drug transporters. So notice there are 4 drug transporters represented by 4 blue arrows in this photo. And notice in this one, it's transporting a lot more medication into that bloodstream. So we're getting a lot more than expected medication into our bodies, and that can lead to those side effects. Another way we can have genetic variation between us is called high-risk genotypes. You may have heard of the famous actress Angelina Jolie, who had the genetic test done to see if she would be at high risk for having breast cancer, and she ended up coming back positive for this test, so she decided to be preventative and had her breast tissue removed because of that. This is along the same lines, so if a patient has certain genes, these patients may be at increased risk for having side effects. For one example, we have carbamazepine. This is a drug used to treat seizures. And for some patients, providers will have these patients get this genetic test done before they give the medication if they're at a predisposing risk factors for this. So we have the HLA-B1502 gene. And if you have this gene variant as positive, you can have a very severe rash when you take this medication, so they would want to avoid taking this medication with these patients who are positive for this genetic variation. So what can pharmacogenomics tell us? So we have all of our patients with the same condition. They're all going to get DNA tested to see what their genes tell us. And then from that, pharmacogenomics can tell us if the patient's going to be a good responder, which is going to be the majority of the patient population, because that's how our drugs are approved by the FDA. And that means medication is working how we expect. And it can also tell us if the patient's going to be a non-responder or that medication's not going to be working. And this just could be because that medication concentration isn't building up in the body as well as it should be. And then it can also tell us if the patient will have bad side effects due to their metabolism as well. So this would mean the medication's working too much and we're getting too much of that drug concentration in the body. Currently, pharmacogenomic information has been identified by the FDA for over 150 medications. However, we don't always use all this information that is available to us. Most common medications that we use pharmacogenomic information for currently are our cancer medications, because we need to target specific things in those medications. So we can see here oncology has more than 80 medications that have pharmacogenomic evidence, but we also see antidepressants have quite a few at 25, and then our heart medications or cardiovascular medications have about 12 that have pharmacogenomic labeling for them. And we're going to go into more in depth into these examples in a minute, but first we're going to start out with one example. So you may recognize codeine. This is a medication used to treat mild to moderate pain. It's usually used in cough syrups. So this medication is metabolized by this certain enzyme called CYP2D6, and this breaks down codeine into its active form. However, this medication has a black box warning, which is the highest warning the FDA can assign to a medication, meaning that they're rare, but they are very serious side effects. So this warning is death related to ultra-rapid metabolism of codeine to morphine. So this picture shows it a bit more clear. So we have codeine. Initially it is inactive, so it's represented by the little circles, and then it goes through the enzyme, and normal metabolizers are most of our patient population. So it goes through that CYP2D6 enzyme, which breaks it down into an active form. So this drug was made by the drug company purposefully to be metabolized into an active form. So it's a little bit backwards of what our usual metabolism is. And then morphine provides that pain relief. However, that black box warning was for ultra-rapid metabolizers, which we can see represented on the bottom half of this picture. So think of it as that enzyme is extra large, it's working really fast, and this is only in 1 to 2% of patients, so it is rare. but it's breaking down that codeine into an active form faster than our normal metabolizers. So now we have more morphine than were expected. And we have more of our pain medications. They end up causing our overdose symptoms, and they can be very serious, leading to trouble breathing and could lead to death. So this is a very serious genetic variation, but is uncommon. So I hope you remember our patient Carl, who came in for depression symptoms. So now, since he's not feeling any relief from 2 antidepressants, his physician decides to order pharmacogenomic testing to look at commonly prescribed mental health medications. So we'll come back to his results in a little bit at the end of this presentation. So now we're going to look at a few health conditions and some pharmacogenomic evidence for them. So some health conditions that have pharmacogenomic evidence for them are heart disease, psychiatry, diabetes, infectious diseases, oncology, and pain management. Today I'm going to go into a few examples in our heart disease and psychiatry. So these are some of our cardiovascular medications that have pharmacogenomic evidence for them. You may recognize some of them. Warfarin and clopidogrel are blood thinners. We have beta blockers such as atenolol or metoprolol that control your heart rate. Statins such as atorvastatin or Lipitor. These are used to lower cholesterol. Diuretics or water pills, also known as furosemide or Lasix. And then we have our ACE inhibitors, such as lisinopril, which also lower our blood pressure. So I'm going to go into 2 examples of warfarin and then clopidogrel after this. So warfarin is a blood thinner used to prevent blood clots in patients that are more prone to having blood clots. It goes through one enzyme that has a genetic change called CYP2C9 and then one genetic variant called VKORC1. Now, it is very common in the Asian population to have these genetic variants for warfarin. So normal metabolism, the drug is ingested, the body wants to break that medication down so it can be eliminated safely from the body. However, with warfarin, we can have what we call poor metabolizers. So think of that enzyme as a lot smaller, and it's not able to work as fast as a normal metabolizer. So because of that, it's not breaking down the medication as well, and we start to get accumulation or buildup of that medication in the body. And when we have a buildup of a blood thinner, it could lead to increased risk of having bleeding. And then we also have clopidogrel, also known as Plavix. This one has that black box warning again. So this one is diminished antiplatelet effect in patients with 2 loss of function alleles of the CYP2C19 gene. So this one's a little different than warfarin in that it is metabolized differently. So when you initially ingest the medication, it is not activated until the metabolizer comes along and metabolizes it into an active form. This is also a blood thinner, so when it's metabolized into the active form, we get no blood clots because the drug is working. However, we can have poor metabolizers on this side, and when we have poor metabolizers, they're not able to activate the drug. So we don't have as much active drug, so that means the drug can't build up to the right concentrations we need, so it's not working. And if our blood thinner is not working, our patients are going to be more prone to having their blood clots. Another common area of pharmacogenomic evidence is in our psychiatry. The antidepressants are our 3rd most commonly prescribed medication in the United States. And less than 50% of our patients with depression respond to the first antidepressant prescribed. And then we have 30 to 75% of patients will stop taking their medications due to side effects. So with antidepressants, they take about a month to work for when you try one medication. So when a patient is trying 2 or 3 antidepressants, that's about 2 or 3 months of not feeling so great. So this is an area where pharmacogenomics can really help us. And then it can also show us which patients are more prone to having side effects with certain medications, and we could potentially limit those side effects. There are a lot of psychiatry medications with FDA pharmacogenomic labeling. I've listed a few here. You may recognize some of them. Citalopram is also known as Celexa. Fluoxetine is also known as Prozac. Aripiprazole is also known as Abilify, and then diazepam is also known as Valium. Now, our psychiatry medications go through two major common enzymes that do have a lot of genetic variation, and these are called CYP2C19 and then CYP2D6. So we can have different things happen with these. We can have ultra-rapid metabolizer. So think of that as that enzyme is extra large, so it's breaking down those medications really fast. And when that drug is eliminated too fast from the body, it's not actually building up enough concentration, so it's not working. And then on the other side, we can have the poor metabolizer, where that enzyme is smaller, and because of that, it's not able to break down that medication as well, and we start to get the accumulation building up, and that'll lead to side effects. Now, I hope you remember Carl. His pharmacogenomic evidence came back that he's a CYP2C19 ultra-rapid metabolizer. So if you don't remember what that means that enzyme is extra large and it's breaking down that medication really fast. So because of this, Carl's physician decides to prescribe another medication called Effexor that is not metabolized by CYP2C19. And because of this, Carl is able to, his medication is able to build up enough concentration in his body, and then he starts to feel like himself again after a month of trying that new medication. So this is just one way pharmacogenomics can help a patient. There are many ways it can have beneficial effects. So what does this mean for the future? It is important to note that not all of our medications are affected by genes, and there's still a lot of other factors affecting medication responses, and we're probably not going to discover all of them for many years to come. However, our genetic tests may become more common and as their use is increased in the upcoming years. So this device here on the right side of the screen is a recently FDA-approved handheld device designed to be used like in the doctor's office, similar to a glucose monitoring test. And what it does is it'll take the patient's blood and it'll test for two common genetic variants that are responsible for 25% of our medication variations. So you could have these results in an hour, and the physician will be able to prescribe the medication that wouldn't affect your metabolism as much. Now, pharmacogenomics has recently become a bigger topic, mostly because of its increased accessibility. So in 2001, that was when the Human Genome Project was done, and that was when scientists were able to fully sequence the human genome, and that cost them $100 million. However, now the price has significantly decreased to about $1,000, which is way more affordable for us now. And then we don't even need the whole genome sequence to see the majority of our drug metabolism as well. So it has become a lot cheaper in recent years, which is why it's become increasingly popular. To look at some of the benefits of pharmacogenomics, it can tell us that best choice of the drug the first time around. So we don't have to try 2 or 3 medications to see which one is working the best. We will know the first time around. And because of this, we'll have improved medication efficacy. That medication will work right the first time how we expect it to. And then as well as that, we'll have reduced side effects, which could reduce doctor's visits and ER visits and end up lowering our healthcare costs in turn. However, there's still some drawbacks. It is still a high cost of genotyping. Some of our poor and more disadvantaged communities may not be able to afford genetic testing, and this could lead to some discrimination. And with discrimination, this does have to do with, unfortunately, our insurance companies do kind of rule our medication therapies. And if insurance companies do find out you're at high risk for having a certain gene or disease state, we're not sure if they'd be able to increase your rates, as well as invasion of privacy along those same lines as who would have access to your pharmacogenomic results. And there are still a lot of knowledge barriers, even with your healthcare professionals. If they had the information, they might not all know what to do with it. So it would have to start being introduced in our professional schools as well, and that would take some time. And there's also lack of clinical trials, which is what we base a lot of our prescribing practices off of. Because there's not a lot of money in pharmacogenomics, the big drug companies aren't going to perform a lot of tests on it, so there's not a lot of evidence out there for some of these tests. So I just wanted to go over a quick 5-question true or false quiz to conclude this presentation. So the first one is pharmacogenomics is the study of how a drug is metabolized. So I know we talked a lot about drug metabolism, but pharmacogenomics is the study of how genes affect individuals' response to medications and not specifically our metabolism. So this one is false. The next one is dosing medications is based solely off a patient's age and weight. So this would also be false. We talked a lot about all the different things that go into dosing a patient's medication, and here are a few that are listed, as well as there's still that haven't been identified yet. Number 3, mutations in drug transport activity can affect how a patient responds to a medication. This one is true. So we talked about how we can have decreased function of those drug transporters as well as increased function of those drug transporters in our body, which can lead to less concentration of medication and then more concentration of the medication in our bodies. Number 4, currently pharmacogenomic information is available for over 150 medications. So this is true, and it is continuing to increase. And then the last one, currently there's no way to test for genetic mutations. And then this will be false. We have the little handheld devices, and we can actually sequence the whole human genome if we would like. All right, just a few key takeaways from this presentation. Pharmacogenomics is a study of how genes affect an individual's response to medications, and we can use this knowledge to tailor patients' medication therapy to their individual genes, resulting in that less of trial and error methods. We're going to get that first drug around, get that right drug the first time around. And then personalized medicine may be the future of medicine. So we may be seeing a lot more of this coming up in the future.